So epilepsy is an enormous topic we can't hope to cover in 1 hour, but what we'll provide is a rapid fire a look at what's happening in epilepsy today and updates on new directions. We'll have 4 speakers, and we have a special treat. We have a patient, one of our patients here with us today to provide you more insight into what she's gone through and the successes that she's had. So no further wastes of time. Let's move forward. Dr. Travis Losey will start off this conversation.
Well, good afternoon. It's wonderful to be here. So just wanted to talk about some of the basics of epilepsy and also some of the foundations of medical management of epilepsy. You can see my disclosures. We'll start by talking about a patient, and we'd like to keep this patient story in mind as we go through the next hour. So at 22 years of age, a female with no prior medical history developed spells where she'd lose awareness and become unresponsive for 1 to 2 minutes. She has no warning prior and no memory of the spell. She was initially started on carbamazepine and was spell-free for 7 years. Then, despite continuing on a therapeutic dose, the spells occurred weekly. An addition of a second medication at a therapeutic dose did not stop the spells. She had an MRI of her brain which showed right mesial temporal sclerosis, and she had a PET scan which showed right temporal hypometabolism. So how are we going to help this patient, and what data do we have to guide us? First of all, when we talk about seizures in epilepsy, we need to have our lingo straight. So seizures are events, and epilepsy is a disease. And when we talk about seizures, we talk about several different types. We have seizures that are focal onset, that begin in one part of the brain and at times spread out. We have seizures that are generalized in onset, that start over the entire brain. And then we have what we call unknown onset, where we're not sure right at the beginning of our evaluations. These are the different types of seizures. And then we have etiologies. What's causing the seizures? Is there a structural etiology, a genetic etiology, infections, metabolic changes? A seizure can be caused by hypoglycemia or hyponatremia. Immune causes, and we are learning more and more about the different autoimmune conditions, paraneoplastic conditions that can trigger seizures. And sometimes we just don't know. The etiology is unknown. Epilepsy is defined as recurrent unprovoked seizures. So we have different types of epilepsy. Focal epilepsy, where seizures start in one part of the brain and spread out. Generalized epilepsy. We're beginning to appreciate some people who have combined generalized and focal epilepsy. And then there are still some cases where we don't know the etiology. And then we put all of this together into an epilepsy syndrome. And we won't get into the epilepsy syndromes too much today, but Dr. Michelson will be talking about some of the exciting information we have about specific epilepsy syndromes later on in the hour. And then we have to consider comorbidities. Not only are seizures a symptom of epilepsy, but mood changes, depression, anxiety can also be seen. And so those are important factors to keep in mind with our treatment. We're talking about a patient who began having seizures at 22 years of age. And we can see that seizures and epilepsy can be diagnosed at any age. The incidence is highest in the very young and as we get older, but even in our 20s through 40s, there are people who develop epilepsy for the first time. Our current knowledge is still limited, where we're not able to put a specific cause on for most people with epilepsy, but as our knowledge of genetics and our neuroimaging techniques expand, we're able to come up with more and more answers. What about odds of control? So this is the best data we have, which was a really well-run study out of Scotland, where they tracked patients from their initial diagnosis of epilepsy over time. And we're able to fully control seizures in about 2/3 of people with epilepsy. But of those 2/3, most patients are controlled with the very first medication. So the very first medication controlled seizures in about half. With addition of a second medication, we get up to about 60%. But once 2 medicines haven't controlled seizures, our chances of fully controlling them with additional medication trials are low, about 5%. 5% is not 0, and so every year I have a handful of patients who do become seizure-free on additional medication trials. But it's still a very low number. And once 2 medications haven't controlled seizures, we start thinking about other approaches to seizure management. When we're choosing medications, it's important to keep in mind that some types of epilepsy respond to only certain medications. For example, the idiopathic generalized epilepsies. There is patient-to-patient variability, so it's a challenge that we're treating individuals, not populations. But finding that medicine that fully controls seizures is very difficult after 2 medicines haven't worked. And also side effects are important. For most patients, these are medications that they'll take for many years. And side effects can be dose-related, things like sedation, dizziness, double vision, and side effects that may occur at eating dose, the idiosyncratic reactions like Stevens-Johnson syndromes, rash, and some of the mood disorders can also occur as either dose-related or idiosyncratic reactions. And it's difficult to predict the side effects a given patient will have before trying. We still don't have the data to predict, who's going to have the rash, who's going to have the mood side effects without giving the medication a try. So close communication with patients is very important. We have a number of newer medications. Time won't allow us to explore all of them in detail. Probably the one that's gotten the most press is the one at the bottom, which is cannabidiol or Epidiolex, which is a marijuana derivative. Dr. Michelson will talk about that a little bit more. But when we're looking at the data that we have, the data for cannabidiol is actually not that much different than many of the other medications that have been approved recently in populations. So it's important to keep these tools in mind for our patients. So when do we consider epilepsy surgery? And the really cardinal fact to consider is if a patient's having disabling seizures despite trials of 2 to 3 appropriately chosen medications, and the medications are tried at therapeutic doses. Sometimes I have patients ask me, doctor, should I have surgery for my seizures? And they'll describe seizures that don't involve loss of awareness. And I'll put the question back to them. I'll say, we consider seizures when we consider epilepsy surgery when the seizures are disabling. Are the seizures disabling to you? Really having that conversation with patients is important. But surgery can be very effective. Dr. Bolling and Dr. Robeson will talk about it a little bit more, and it can be an excellent option for our patients when medications have failed to control their seizures. So I'll just hand off, and we'll circle back to our patient at the end of our talk.
Thank you, Dr. Losey. So epilepsy, as Dr. Losey mentioned, is in fact a common problem. About 1.2% of the population suffers from it, which is a large number in the United States. In California, nearly 500,000 individuals have epilepsy. If you look in our little corner of California, the Inland Empire, it's over 51,000 individuals with active epilepsy. So it's a big problem. And the major issue around the epilepsy is the fact that a large number, around 30% of individuals, will fail medicine or be medically intractable. The definition is failure of 2 medicines. Could be any 2 medicines, but as Dr. Losey mentioned, the odds of success after failing 2 is very low, and that's the definition of medically intractable. Medically intractable epilepsy carries with it a reduced quality of life for the individual. There's stigma related to it. There's cognitive decline that occurs with ongoing and recurrent seizures. And there's a significant mortality, mostly due to a syndrome called sudden unexpected death in epilepsy, but other causes as well. There's a cost to intractable epilepsy. In California alone, the economic burden is around $1.2 billion per year from visits to the emergency department, taking medicines, and everything associated with it, injuries, etc. What's the solution? The solution is to stop the seizures, and seizure freedom reduces mortality rates to the same as age-matched controls, significantly elevates quality of life, and reduces stigma. In order to investigate individuals who failed medicine, to look for opportunities for cure, to stop the epilepsy, we first bring them into the hospital, record EEG with video, we call the epilepsy monitoring unit. We get imaging. Imaging is the other pillar of the evaluation of the individual with intractable epilepsy. And in this case, you see the arrow pointing to the most common abnormality we see on MRI. It's a scar within the hippocampus in the temporal lobe. The most common type of epilepsy that we see and operate on that's failed medicines is temporal lobe epilepsy. And for many of these individuals, we can do surgery through very small, minimal access keyhole approaches. We call this surgery a keyhole selective amygdalohippocampectomy. Long words, but very descriptive of what we do. It's selectively removing just the inner part of the temporal lobe, the amygdala and hippocampus, and nearby structures. The success rate's very high. 75 to 80% of individuals will be seizure-free, cured from their epilepsy with surgery. And even more will be substantially benefited. What I've never seen in my experience is anyone getting worse after surgery, which is a common question I hear from patients. There's other abnormalities. Increasingly, we're seeing developmental problems called neuronal migrational abnormalities. It can be subtle or it can be quite obvious on imaging, but even the microscopic forms can cause very severe and intractable epilepsy. If we can find these on imaging and remove them, most people are seizure-free. And this image shows a seizure focus that was removed at surgery, and you see the thickened cortex compared to the normal gray matter here. The gray-white margin is blurred. These are all the signs of abnormality in neuronal development. So it's congenital. It happens during brain development, and it's called neuronal migrational abnormality, increasingly recognized as a very important cause for intractable epilepsy. Here's some other neuronal migrational abnormalities, one called subependymal nodular heterotopia. There's gray matter that should not be here. It's very epileptogenic. It's called focal cortical dysplasia. That's gray matter that's thickened and abnormal and very important cause of epilepsy. Many patients, however, do not have obvious abnormalities on their MRI. The EEG can be unclear, and increasingly we're seeing these complicated patients that require electrodes to be placed in the brain, targeting structures and recording from regions of the brain to be confident of our seizure-focused localization. We use a technique here called Stereoelectroencephalography. Recently has benefited with a robot that we have here at Loma Linda for robotic stereoelectroencephalography. And this robot allows very efficient and precise placement of electrodes, targeting very specific structures and regions of the brain to confirm seizure-focused localization. We can place electrodes basically anywhere in the brain. We have very specific electrode insertion plans for different scenarios, but all to gain this three-dimensional analysis of the electrical signal of the brain and localize the seizure focus. The most common scenario is a bitemporal implantation. Many patients, the EEG becomes confused. It cannot determine whether seizures start on the right or the left temporal lobe. But by placing the intracranial electrodes, usually we can sort it out, and usually it's starting just in one hippocampus, and this is a seizure starting in the right hippocampus and rapidly spreading to the contralateral side. So in conclusion, epilepsy is a dangerous and disabling disease. The vast majority of individuals, particularly those with an obvious abnormality on MRI, can be seizure-free after surgery, and so we go to great lengths with imaging to look for abnormalities. These neuronal migrational abnormalities can be more challenging. What we see on imaging, for example, could be only the tip of the iceberg of a larger abnormality. But most of these individuals can be seizure-free as well. Seizure freedom eliminates the excess mortality of intractable epilepsy, improves quality of life, and reduces stigma. Importantly, for individuals who've failed just 2 medications and are continuing with seizures, they should be evaluated in a comprehensive epilepsy program to look for opportunities for cure. So thank you. Dr. Aaron Robinson, my partner and pediatric neurosurgeon, will continue on from here. Thank you so much.
Thank you, everyone, for making it after lunch. I know this is kind of about the time of the day that I start to take a nosedive in my attention, so we'll keep this pace up here quickly. No disclosures. I just want to pick up actually exactly where Dr. Bolling left off, and just I think we can't say it enough that intractable epilepsy can be treated. This is, I think, from the International League Against Epilepsy. This is a flow chart that they provided, basically outlining what the recommended treatment paradigm is for patients with intractable epilepsy. And I think the part that we care about is this one here. Basically, as everyone said, 2 or more antiepileptic drugs still having seizures means you have intractable epilepsy. Unfortunately, though, a number of centers have looked at this and find that about less than 5% of patients with intractable epilepsy who are potential surgical candidates ever actually make it to that step. And I think there's a number of factors for that. Some of it is lack of sort of provider awareness of further options, but a lot of it actually has to do with patient reticence because surgery sounds scary. So I think what I want to do here is basically demystify it a little bit and hopefully convince you that surgery is not quite as scary as a lot of patients think that it is. And this matters a lot. There's in 2017, a group from India came out with what I think is the only modern randomized controlled trial of epilepsy surgery. They had about 150 kids, and they randomized half of them to surgery up front and the other half to medication alone. And in pretty much almost every single outcome measure they looked at, there was a very substantial improvement in the outcomes with children who immediately went to epilepsy surgery. And obviously there are patients who are candidates for surgery. I mean, most profound, you can see seizure freedom. And this is pretty representative of my experience. Most kids who have epilepsy surgery for appropriate cases have about a 4 out of 5 chance of complete seizure freedom post-op, as opposed to about 5 to 10% with seizure medication alone. But also important is that a lot of the other outcomes showed improvements too in terms of quality of life, behavioral assessments. And it matters how early you get to this, because there's a lot of developmental potential that kids lose out on if they continue to have intractable epilepsy. So what are some of the new ways we have of treating epilepsy? Obviously, every patient that we see and every patient with intractable epilepsy has to have an individualized plan based on the specific type of epilepsy they have. And so not every patient necessarily would qualify for all of these options. One of the newer options that's been around for about 10 years now is what's called laser thermal ablation. And this is something we have here at Loma Linda as well. And basically what it is it's nothing really that new. We've been sort of burning and ablating things in the brain for a while, but what differentiates it is that we can do this in an MR scanner, so we can very, very specifically target deep structures in the brain, including the mesial temporal lobe, the hypothalamus, deep lesions like tuberous sclerosis, gray matter heterotopia, for which the morbidity of surgery used to be quite high, which we can now treat pretty minimally invasively just using thermal ablation. And basically what we do is we put these patients in the MR scanner. We place a small laser applicator through a tiny burr hole. It's about a few millimeters, about 3 millimeters in size. This is a frame base. As Dr. Bolling showed, we actually use a robot to do this here at Loma Linda, so we're even more sophisticated than this. But goes into the brain. We take patients to the MR scanner, and in the MR, we monitor the actual ablation using MR thermometry, which the physics of which I won't go into in this context, but we actually are able to track in real time the temperature of the tissue and track which tissue is being treated and which isn't. And so we can treat lesions like this, which is a hypothalamic hamartoma, which is right next to the optic apparatus, the hypothalamus, a lot of very critical structures. And we can very selectively ablate the hamartoma, which is a frequent cause of epilepsy, gelastic seizures in young infants and children without damaging any nearby tissue. Another common use for visual ablation or laser ablation is in mesial temporal sclerosis. Mesial temporal sclerosis can be treated either with open surgery or with laser ablation. There's advantages and disadvantages to both. Open surgery has slightly higher rates of seizure control. Laser ablation has somewhat lower rates of seizure control with better cognitive outcomes. And so it just is another option that patients have who may have some aversion to having an open surgery. Most patients stay overnight in the hospital for 1 day. The incision is about the size of a mosquito bite, and so it really actually looks like the kid kids. I do kids, so it looks like the kid got a mosquito bite after surgery. There's no big incision. And I think for a lot of families, knowing that this is a potential option makes the idea of surgery a lot more palatable. And really, actually, the thing to emphasize is that a lot of these surgeries, whether it's laser ablation, whether it's the keyhole surgery that Dr. Bolling mentioned, are potentially curative. It's potentially, in as many as 80% of cases, we can actually cure the patient's epilepsy, and they can go on with their life without ever having to think about epilepsy again. Some other sort of more palliative procedures are neurostimulation. Neurostimulation doesn't cure patients' epilepsy, but it does significantly reduce their seizure burden to the point that their quality of life is improved. The oldest method of neurostimulation, this isn't exactly new, and is probably well known to a lot of people, is what's called vagal nerve stimulation. Basically put a little wire around the vagus nerve in the neck, hook it up to a stimulator that looks like a pacemaker in the chest, and continuously stimulate the vagus nerve. We're not entirely sure why this works. The vagus nerve has diffuse afferent projections to the entire brain. So it's basically, we're just piggybacking the brain's sort of intrinsic wiring by putting this stimulator on the vagus nerve. It somehow desynchronizes the EEG to sort of distract the brain and prevent seizure activity from building up. The responder rate for vagal nerve stimulator, meaning the number of patients who have about a 50% reduction in their seizure frequency, is about 50 to 70%. And that number is about the same across all types of neurostimulation. Another type of neurostimulation that we now have is NeuroPace. This has also been around for a number of years now, but it's still relatively new. It's basically described as a pacemaker for the brain. What it does is you have this little device, either a strip electrode or a depth electrode, that sits in the brain where patients are having focal seizures. So this does require someone to have focal seizures, but if it's a patient, for instance, who has seizures from their motor strip or some eloquent area of the brain where a resective or ablation surgery would pose an undue risk of weakness or other deficits, you can place these electrodes, which don't cause any sort of damage to the brain tissue, and it will continuously monitor the brain activity, and if it detects a seizure, it will attempt to stop the seizure before it actually propagates. It does involve an actual opening in the skull. You have to put this little battery that you can see here over the surface of the skull, not actually in the brain, but in the skull itself, and then there's typically 2 or 3 electrodes that sit on the brain to both detect and treat the seizures. This just shows the response in various areas of the brain. It's very similar response rates to vagal nerve stimulation, but a little more focal. And responder rates about, again, 50 to 70% with median change in seizure frequency of about the same 50 to 70%. More recently, this has actually been used for a while experimentally, is deep brain stimulation. There's just recently a company got approval, FDA approval for use of deep brain stimulation in the anterior nucleus of the thalamus, which is the one right here, the anterior nucleus of the thalamus. And they got similar types of seizure reduction to VNS and NeuroPace. So it's basically, we have multiple options at our disposal now. It's not just VNS, it's not NeuroPace, not just open surgery. There's multiple options. And so I think it's important that patients know that, getting surgery for epilepsy doesn't consist of taking half your skull off and, staying in bed in a hospital for months. It could be as simple as coming in the same day, getting a simple procedure, and having some significant quality of life improvement. And so if I can just, reiterate, again, I think, as providers out there, I think it's important to remember that just a fraction of patients get the appropriate care, and a lot of that is, patient reticence, but it's very important for patients to be aware that there's options available to them. I think a lot of it I see in pediatrics, parents don't even realize that there are other options. Epilepsy isn't like, it's not like a cancer diagnosis where there's a sense of urgency to it, but it is potentially life-threatening. And so it's heartbreaking when I see patients who've been suffering and had seizures almost their entire life until they see me, who could have been treated earlier on. Because particularly in the pediatric population, the clock is really ticking. The sooner you can treat patients and cure them of their epilepsy, the greater their developmental potential afterwards. And I think it's important to remember that there's always new innovations, and so even if a patient wasn't treatable before, it's very possible, 5 years from now, 10 years from now, that we may have new options available. And with that, I just want to continue. continue on and pass the torch to Dr. Michelson, my colleague, also in pediatric neurology and epilepsy.
Thank you, Dr. Robeson. Perfect. The green one means go, right? So thank you for the invitation to talk to you a little bit today. This great panel of people that treat epilepsy in different ways. As a pediatric neurologist, I do get to see some of that highest peak of incidence that Dr. Losey was showing you when epilepsy is first recognized and diagnosed. Some of that percentage is, of course, all the various kinds of traumas and non-genetic disorders that can occur at any time of life. But a large percentage of it is genetic disorders. And so I'm going to talk to you a little bit about our recent insights into the genetics of epilepsy. So as mentioned, epilepsy is a fairly large burden on us, society. About 1 to 2% of the population will at some point experience recurrent seizures. Single gene disorders, where you think about something that's just a single syndrome, you can point to one gene that is provoking those seizures, is maybe only 3% of all of that. And as our genetic testing becomes more advanced, we're not really expecting to find a lot more of these single gene syndromes, but we are expecting to have a deeper understanding of polygenetic risk of seizures, things that can run in families as a increased risk, but not necessarily as an autosomal dominant trait. We are trying to make progress towards more personalized medicine, but before we get there, we'll probably have a better ability to be precise in treatment. So not all of our patients are surgical candidates, but when they are, we want to be precise and personalized for them. For our possibly genetic or idiopathic epilepsy patients, we're also hoping that we can tailor their treatment to their specific genetic disorder. And we are making good progress in that way. So the first of these conditions that I want to focus in on a little bit is Dravet syndrome. So I have several patients with Dravet syndrome. I didn't know that I had any patients with Dravet syndrome just 10 years ago, but I probably have always been taking care of them. As our ability to have access to genetic testing has improved, we're realizing that these patients have always been with us, and we just called them medically intractable or said they had an idiopathic epileptic encephalopathy. But now with the access to genetic testing improving, we are being able to specify which of our patients have this specific syndrome. So this one is caused by mutations in a voltage-gated sodium channel. The SCN1A gene encodes the subunit for it. And this is selectively expressed on GABAergic neurons. So the loss of excitation in these inhibitory neurons leads sort of in total to a loss of inhibition in networks within the brain. So increased excitability of the brain and the seizure activity. This is maybe 1.4% of all childhood epilepsy with an onset prior to 15 years old. So it's not really that rare of a genetic condition, but we're only starting to recognize those patients as we test them. And Dr. Losey and I were talking a little bit about our need to revisit cases of adult patients with childhood onset epilepsy that were never tested when these tests were not yet available. So these patients typically present initially with what seem like febrile seizures. You know, their first seizure is during an illness with a high fever. But what's somewhat characteristic and not necessarily as typical of febrile seizure patients is that they will present in febrile status with very prolonged seizures. And they'll do it recurrently, and they tend to do it before they're even a year old. So if we start to see that pattern, even if they haven't yet developed unprovoked seizures or any developmental disability, we are aware now to start testing those patients for Dravet. As we test them initially, they may have normal development, normal backgrounds on their EEG, normal imaging, and we wouldn't expect a family history because this is a dominant mutation. But as we test them later on in life, we see that they've developed multiple seizure types, not provoked by illness, and that their development regresses. They may become autistic in some respects, or they may just seem like they have intellectual disability. Their EEG becomes slow even in between their seizures, and as Dr. Bolling and Dr. Robeson both mentioned, there's a high burden on these families and on the children themselves, including their mortality. This is a case of Dravet syndrome that made quite a lot of news. What is it, 5 years ago? 6 years ago now? And this may be familiar to you if you don't remember her name, but this is Charlotte Figge, and she had intractable epilepsy with developmental regression related to Dravet syndrome. She was treated with medical marijuana, and her seizure control became excellent. She went from having hundreds of events a day, including multiple generalized tonic-clonic seizures a day, to maybe 1 or 2 events per week total, with no further drop seizures, no more grand mal seizures. So there was a clinical trial for cannabidiol made by GW Pharma and now marketed as Epidiolex in patients with Dravet syndrome. And as Dr. Losey was saying, the results in that group were about as good as we would expect to see with a new adjunctive therapy for epilepsy in any population. That is remarkable in Dravet patients. These are all patients that were enrolled in this trial that had failed at least 4 medications, sometimes 10 medications, and were still suffering a very high burden of seizures. So anything with potential for benefit for these patients was very welcome. This has generated quite a lot of excitement in the community of epilepsy families as a whole about the potential for cannabidiol to benefit them too. We just don't have as much information about the general population yet. But the FDA used the information from that trial and a second one in Lennox-Gastaut patients to approve Epidiolex for use in patients. And now I have about 15 patients that have gotten insurance approval, which was the next hurdle for them to jump to start using this as treatment. Some of the patients were already using artisanal forms of cannabidiol extracts, paid for out of pocket, and they really appreciate being able to get this medication from a reliable source, but also to stop paying out of pocket for it. Other families are just excited to have another opportunity to treat. There are other treatments that are being researched for this specific condition of Dravet syndrome too. There's this article out from last year of a game-changing treatment for kids with Dravet syndrome. So we keep seeing individual reports like this in very small subsets of our patients, but it increases our excitement and drive to keep looking for specific syndromes in our patients so that we can more personalize or strategize for our patients. Here's another specific syndrome I wanted to have a chance to talk about. This is ADNFLE, a long acronym. It's for autosomal dominant nocturnal frontal lobe epilepsy. It's very rare. I've only seen 1 case so far in my career, but the genetics of it, they are 3 different genes now that have been found to be able to produce this phenotype where you have sometimes very frequent seizures in sleep. They're odd seizures because they come from the frontal lobe, and they're sometimes misdiagnosed for quite a while as night terrors or nightmares or even psychogenic non-epileptic spells. Because the subunit for these genes is in the sodium channel that's nicotinic, it did occur to some people that there might be a specific treatment for these patients in using nicotine. And here's a story out of Florida of a girl who had a great response to using nicotine patches for her epilepsy. I wasn't surprised by this story because I had that experience with my 1 patient. We talked about this idea. The family wanted actually to try cannabidiol first, but I talked them into trying nicotine patches, and the child's now been seizure-free for 3 years. He used to have 50 to 70 seizures every night and would wake up exhausted, moody, would have a really hard time with his behavior and his learning at school. And he's been doing really well since then. They actually moved out of state, so I haven't been able to follow him personally, but I just got an update from the family. He's still doing that well. And all they do is put a nicotine patch on him every day. They had to learn not to take it off because he would go through withdrawal. Here's the third syndrome I wanted to get a chance to tell you about. This is called GLUT-1 Deficiency. And this is for a transport protein. This is a gene for a transport protein that moves glucose across the blood-brain barrier. So as you might expect, you have normal glucose levels in the serum, but you have low levels of glucose in the CSF, hypoglycorrhea. We usually associate that with some terrible inflammatory disease blocking the transport secondarily, right? Meningitis, cancers, granulomatous diseases. But in this situation, there's no other illness. It's just this deficiency of transport. The primary problem is not the hypoglycemia of the nerve cells. They seem tolerant of that. It may actually be a problem with the use of glucose in the brain as a source of carbon for growth. When this is a congenital disorder, these children have spasticity, microcephaly, global developmental delay, and epilepsy. And treatment for these patients with anti-epileptic medications is generally disappointing. You may be able to give them some improvement in control, especially in the milder cases. But the severe cases have onset of epilepsy in the first few days of life, and they won't really respond to any treatment until this is recognized. And it's been known for a while that you can treat these patients with the ketogenic diet. What is that doing? It's giving the nerve cells an alternate source of fuel and maybe somewhat of carbon for growth and development. And we're generally happy with the results. There isn't normal development in those cases, though. So there's still research being done on alternative ways to treat these patients when they're recognized. But as you can imagine, not every family is happy to have us do a lumbar puncture on their child because they've had one seizure. So we haven't recognized this in every case just from their clinical presentation. But because we now know the genetics of it, and we can test for genetic abnormalities in addition to when we have the chance to do lumbar punctures, we are recognizing cases of this, and it's expanding the phenotype. So we used to think of this as only causing intractable epilepsy, microcephaly. Now we know that with milder cases, they can have fasting-induced seizures or even movement disorders like dyskinesias. So we're on the lookout for those patients now too, and we can offer to do genetic testing rather than just lumbar puncture. Here's another nice little news story about a happy family where this diagnosis was made in time to reduce this child's burden of epilepsy and allow her to continue with normal development. Ketogenic diet doesn't have to be a kilo of cream cheese, but it's kind of a clickbait headline, right? So, as I mentioned, our genetic testing is becoming more detailed, and we're having improved access to even the most detailed tests. We're talking to our geneticists now about having a strategy of ordering whole exome sequencing as a first-line test for patients with intractable epilepsy, skipping past karyotypes, microarrays, even gene panels. There's only been a few articles published so far that have tried to analyze the cost effectiveness of those different approaches. And some of them actually do support that if you have access to all these tests, you may actually save money doing the most expensive test first because it has the highest yield. So we're currently thinking we can get about a 45% yield from whole exome sequencing in patients that do have genetic epilepsy. So it's not 100% yet. There are probably some genes we don't sequence well, even in those panels. There are probably some epigenetic phenomena that those tests are not sensitive to, and beyond, more things that we have yet to understand. But we're also understanding more and more the benefits that come with using genetics as a third pillar of our approach to epilepsy. We can end a diagnostic odyssey. They've had their EEGs, they've had their MRI. We still don't know. They're still in their undefined category. There wasn't a family history to suggest a definite epileptic genetic disorder. But if we can find an explanatory gene disorder, that does end this diagnostic odyssey. We can end parental doubt, sometimes blame and shame that they feel over having a child with a developmental disorder. We can provide them with reproductive risk information that they may or may not use in deciding on having future children. It may also benefit other family members throughout their family tree. We sometimes identify treatable metabolic disorders. We think of this GLUT-1 deficiency as a metabolic disorder, and it has a metabolic treatment, which should only improve over time. There are other treatable metabolic disorders like pyridoxine-dependent epilepsy, which we would recognize on a genetic test, even if it didn't occur to anyone to test their alpha amino adipic acid levels, because it may not fit the exact phenotype people are expecting. So as our understanding of the range of phenotypes improves, we'll maybe catch up. But doing broad testing like genetic testing sometimes helps us recognize odd or mild phenotypes. It will sometimes suggest specific anticonvulsants to give, so I wouldn't necessarily give a nicotine patch to any other patient. But if we recognize the ADNFLE, that is something that we can do specifically. There's also increasing information about certain anticonvulsants to avoid. So in Dravet syndrome, because it's a sodium channel abnormality, we have actually found that some patients with Dravet have increased seizures when treated with medications that are sodium channel blockers. And then some of this genetic testing is available to families because there are pharmaceutical companies trying to find patients for their clinical trials, so they make the genetic testing free. So there are clinical trials for an increasing number of genetic epilepsies, and we want to allow our patients to participate in those if they want to. And then there are some genetic epilepsies that are structural too, like tuberous sclerosis. But we also think about all of the advanced planning and the screening tests that we can do in our patients with tuberous sclerosis that we wouldn't know to do if we didn't know why they had epilepsy. And not all patients with tuberous sclerosis have totally recognizable MRIs, so we've missed a few. I'm going to yield my time to the chair and have our patient come back and talk a little bit about her experience with epilepsy, and that will be our panel.
So just wanted to introduce Wendy. So Wendy was our patient who we talked about at the very beginning, and I'll just ask her to tell us a little bit about herself and how she's done since she started treatment.
Hello, I first was diagnosed with epilepsy back when I was 22. This was when I was in nursing school. I did good with just the medications that I was placed on. However, 7 years later, I was referred to Dr. Losey because my seizures came back. So within a year, I was referred to Dr. Bolling. That was back in 2016. I underwent the keyhole surgery July 2016. First, yes, I was afraid, but they did an excellent job of explaining why I was a perfect candidate for it. It was on the right temporal lobe. I think my biggest concern before going through the surgery was knowing what if I didn't remember how to be a nurse, basically. That was my biggest concern. However, I went the keyhole surgery. The next day, I was discharged home. 8 weeks later, I was back at work. Within a year, I could drive again. And then just last year, I transferred over to the neuro ICU department. So now I can work with the seizure patients. So I can tell them from my personal experience, because I do see them like they're afraid. That's why they don't want to do the keyhole surgery. I'll show them my scar, and I'll just tell them, see, I'm normal. I think I'm normal. You'll be normal too. Just to give them the courage that they need, because a lot of it is lack of education and just the fear of knowing that they're going to basically do an incision in your head. But I've been doing great ever since.
Thank you very much, Cindy.
We will open up for some questions. Anyone on the panel? Question.
One of my questions is, what are the complications of vagal nerve stimulation, cardiac complications especially? And the other question is, GLUT-1 deficiency, and which is exacerbated by testing. Could you please elaborate on GLUT-1 deficiency in terms of duration of testing?
Yeah, so I can address a little bit about the VNS first. So cardiac complications with VNS are extremely rare, but there is a rare risk of bradycardia or bradyarrhythmia. That's usually detected in the operating room when the surgeon activates the VNS for the very first time. The risk is less than 1%, though I have had a single patient who had that. You know, in the operating room, the anesthesiologist is right there, and the device can be turned off immediately. So for the one patient who I have, it wasn't a serious issue. He just couldn't use it. But that's a very rare side effect. The more common side effects would be things like dysarthria, an effect on the vagus nerve directly. But those are side effects that generally can be addressed through adjustments of setting.
Just also the vagus stimulator, the risks of surgery are approaching zero. The only problems I've seen over the years is rare infection. If an infection occurs, you may have to remove the device, but even that's been very rare. So the surgical complications are approaching zero.
I think there's at least some theoretical risk of exacerbating obstructive sleep apnea, but the most recently developed version of the device allows you to change the settings at different times of the day. So you can decrease the intensity of the stimulation at night when they might be asleep, and that can reduce the risk if that is noticed. As far as the GLUT-1 deficiency and how long it takes for fasting, it's very patient dependent. So it's hard to say that there's always a certain amount of time. I had one patient that I suspected the condition in, but I have not yet had a patient. So all of my knowledge is based on what I've read, and I keep looking for a patient with this condition because I have a treatment ready for them. But you know, what I've read is that in some cases it's just that they've gone a little bit longer between meals and they feel like they are developing dyskinesia, like an exercise-induced kinesia can be a result of that syndrome in a mild state. And the very severely affected kids, I don't think they've really recognized that there's that much of a fasting dependence to their epilepsy. But you know, occasionally we'll get families that tell us that their child's seizures are better when they're sick rather than worse. And I don't know what that really is at a metabolic level, but I suspect that they're actually in ketosis because they haven't been eating well, and it's suggesting they might be good candidates for the ketogenic diet.
We have another question over to your right.
So I mean, as I said in my talk, it's hard to really, every patient is different, and so if you have a very high functioning individual, 17 years old, who has a dominant temporal lobe lesion, it really depends where it is in the temporal lobe. And so there's, a number of factors that could make surgery in her case a little more high risk if she has a lesion that's near eloquent cortex. But, as I showed you, even if you do have a lesion, a seizure onset zone that is, say, in your speech generation area, there are other sort of not necessarily curative, but palliative options, including, at the simplest level, VNS, but also things like NeuroPace, where you very specifically treat that single lesion. And so I don't think that there's, really any patient, for which there's really no options. And so I think that's the important thing, is even if you can't do a keyhole surgery or a specific operation, there are things that aren't necessarily curative, but are palliative. And so sometimes, it's hard to know in an individual case if it's the reticence of the patient or the reticence of the surgeon. But I think, the reality is that there's very rarely no options available. It's just a matter of whether it's a curative option or more of a palliative option. And palliation is not to be overlooked. I mean, with these sorts of neurostimulation, there is a very significant reduction in sudden death due to epilepsy with the neurostimulation, such as VNS. DBS hasn't been around long enough, I think, to really know, but NeuroPace as well. So I've had patients who have died from epilepsy. It's not a benign disease, and so I think it's important for people to know that, it's important to treat it in some fashion. And so it might be worth looking into to see where the roadblock is in that case, and keep nudging the patient along.
We have another question right back here.
Yes, my question is removal of a lesion, a scar in the brain, and I mean, I'm always thinking about another scar, the place where you remove something. Is that?
Yeah,
is it different for the brain?
This is the second most common question I'm asked as a surgeon, and it's true that surgery creates some sort of scar, but we know from our experience that the surgical scar is different from the scar of trauma or infection that led to the epilepsy. The surgical scar is extremely unlikely to be a cause of epilepsy. We describe it as a clean scar versus a more messy scar related to the other epilepsy etiologies. So practically, the answer is the surgical scar is extremely unlikely to be a cause of epilepsy.
Question back here.
What is the current treatment for recalcitrant pseudo seizures?
That could be another hour-long talk. So psychogenic non-epileptic spells are thought to, or pseudo seizures are thought to be a somatoform disorder. And so they're often involuntary. Cognitive behavioral therapy is an effective treatment. And there's also a program in our Behavioral Medical Center here run by Dr. David Puder that's actually a partial hospitalization program that really looks at all of the psychological underpinnings of the spells. What we do find is that with effective treatment, at least a third of people with psychogenic non-epileptic spells can become spell-free. The outcome is better in people who've been recently diagnosed, but it is definitely a treatable condition. And there's a lot of research being done in that field as well.
Next question.
We had a 28-year-old nurse that was her seizures were well controlled with medication, who had died in the middle of the night. So how do you decide what to do with someone whose seizures are well controlled?
So sudden unexplained death in epilepsy, or SUDEP, is the really diagnosis when seizures cause a person to lose their life unexpectedly. The risk factors, first of all, are uncontrolled seizures. So a person who's continuing to have seizures is at higher risk, particularly generalized tonic-clonic seizures. Other risk factors are people who live alone, and also people who are intermittently compliant with treatment. So really our current approach is to control seizures aggressively. Epilepsy surgery has been shown to reduce the risk of SUDEP. So that would be an unusual case where a person would have unexplained death after surgery. But the risk in people whose seizures are uncontrolled is about 0.5% per year, so 1 in 200 per year. So for those of us who see a lot of patients with epilepsy, it's something we do encounter. So treatment is really the cornerstone of our management.
It's really devastating when it happens, and it happens to all of us as treating physicians. Another risk factor I don't think you mentioned yet is nocturnal seizures. And a lot of families talk to me specifically about how afraid they are to let their children sleep in their own bedrooms. And that kind of goes to another comorbidity of having epilepsy as a child, is that your world is a small bubble. People don't really allow you to grow up in the same way that you would if you didn't have this hanging over you. Families are asking a lot about whether there are ways to monitor patients for seizures, and there are some attractive new options out there besides just putting on a pulse ox and being woken up 30 times a night for it going off incorrectly. There are some wearable devices that will monitor patients for convulsive seizures, for tachycardia, for changes in skin electrical conductance, and all three of those things help to reduce the false positives and to help with seizure detection, maybe just alerting a caregiver that's in another room or even asleep in the bed next to them that a seizure is occurring.
We have time for 2 more questions. Over to your right first.
Question about the neurophysiology of why when you ablate the hippocampus or do a keyhole surgery, you don't have memory loss, and is there some way to test beforehand to predict the risk of that happening?
Yeah, memory is the major preoccupation when we operate in the temporal lobe. And of course it's complicated, but simply the dominant hemisphere and dominant memory function is the most important. That's more verbal memory. We live in a more verbal world. So a decline in verbal memory would be something the patient would notice more than the non-dominant hemisphere, which is visuospatial memory. Most people don't really notice a decline there. So if a person's high functioning, they have a normal dominant hippocampus, then we certainly take more pause, and there's a lot more discussion about whether there would be a deficit and whether it would be a deficit that would cause disability, where do we remove a dominant, normal functioning hippocampus. And then there's the question, if the seizures are so severe, that it may be worthwhile taking that risk and taking that hit in memory. So that's always a complicated question, and it's also become one of the prominent roles of some of these palliative approaches in patients who may have normal functioning memory. They don't want to take a hit. We can put electrodes and stimulate and preserve function, yet also have at least a palliative benefit for the patient.
And there are also several tests that we do before surgery that can help estimate the risk. One of those tests is the intracarotid amibarbital test, where we actually put the hemisphere to sleep and do neuropsychological testing. There's also functional MRI, where we're able to gauge which hemisphere is more important for language. And also standard neuropsychological testing to find out what a person's neuropsychological strengths and weaknesses are is helpful. And when we're doing surgery to remove a part of the brain that's already scarred or already not functioning at its fullest, we find that we often don't notice a decline in memory, and especially in non-dominant surgeries, we can see an improvement in neuropsychological function after surgery.
I haven't noticed any changes.
Yeah, that's great. And I think it's even more the case with pediatric epilepsy surgery that we have a high hope that development will actually improve after removal of a surgical lesion.
One last question.
I'm not sure if any of you people have experience with this syndrome, but this patient was being treated for epilepsy for a prolonged period of time for these convulsive episodes, and the asystoles were cured by a pacemaker.
That's one of the advantages of epilepsy monitoring. I have had a patient who was referred to me for seizures who ended up having periods of asystole. And it's amazing how quickly the cardiologist came down to help that patient once we had the EKG.
We actually have one last question.
I just wanted to know whether animals are ever used to notify someone that they're having a seizure.
Yes. That's one of the things that families do ask about, whether they can have a service animal that is trained to alert other people if their sick family member is having an aura or a convulsive seizure.
So dogs are most commonly used. There's a great deal of variability from dog to dog. And I do have a patient who got a discount on a dog who didn't pass the service test, and he sleeps through all of that patient's seizures. But there are some dogs that can either detect seizures or predict them, and that can be helpful.
Let's give our panel a round of applause. Thank you very much for that very up-to-date and thoughtful presentation. Thank you.